Hello everyone. Today we will be discussing the management guidelines of Kawasaki disease. In a OPD, a 4-year-old child came with fever for 5 days. There is redness of the eyes. There is a cervical node. There is redness of the oral mucosa. What you will think of? What is your diagnosis? Yes, it is Kawasaki disease. What is Kawasaki disease? It is the vasculitis of medium-sized blood vessels. And what is the most dreaded complication? It's coronary aneurysms. So, early treatment of Kawasaki reduces mortality from coronary aneurysms. That is why we should identify it and treat it appropriately. See the picture. It shows the diagnostic criteria for Kawasaki disease. That is fever for 5 days or more, bilateral non-exudative conjunctivitis, peripheral edema, unilateral cervical lymphadenopathy more than or equal to 1.5 cm, polymorphous rash, and erythematous oral mucosa. What investigations you will do in such a case? Unfortunately, there is no diagnostic investigation, but definitely you have to do a full blood count, which will show a neutrophilia, and thrombocytopenia will be there in the early stages. Late stages will show thrombocytosis. Inflammatory markers will be increased ESR and CRP. Elevated liver enzymes, bilirubin, and hypoalbuminemia. Sterile pyuria. Urine will show a lot of pustules, but urine culture will be negative. That is sterile pyuria. If you take an ECG, it may show a T inversion ST depression. Echocardiography you have to do definitely. Then you have to do a throat swab and ASO titer. Why? Because scarlet fever, streptococcal infection is a close DD of Kawasaki disease. And as it is a fever with rash, you have to do a viral serology also. If available in your center, you have to do EBV, CMV, Parvo and enterovirus serology. Another thing which you can do is the viral markers for measles. And what is the treatment? We should identify Kawasaki early and treat it immediately. We should start with aspirin. What is the dose? 7.5 to 12.5 mg per kg, 6th hourly, until the patient is febrile. Then you have to start with IVIG, intravenous immunoglobulin, 2 gram per kg as a slow infusion over 12 hours. You have to start it very slowly. Watch for any reaction, any anaphylaxis. If there is any reaction, you have to stop it and then wait for 15 minutes and then restart. If there are high-risk features, I will discuss it later. If there are high-risk features, you have to add methylprednisolone. How much is the dose? 0.8 mg per kg, IV, 12th hourly, for 5 to 7 days or until CRP normalizes. What are the high-risk features? We will discuss in the coming slides. Then, this is the immediate treatment. How you will manage subsequently? If there is persistent fever after 36 hours of completing IVIG, you have to give a repeat dose of IVIG. Even after repeat IVIG, there is a high fever, have to consult Paediatric Rheumatology Department and discuss regarding methylpred. As we said earlier, methylpred in high-risk features cases, you have to start early. Otherwise, after second dose of IVIG also, fever is still high persisting, you have to discuss with Paediatric Rheumatology regarding starting methylprednisolone. And if the patient is febrile for 48 hours, CRP is falling, and there is clinically the child is improving, you can reduce the aspirin dose to 2 to 5 mg per kg once daily for, you have to give it for 6 weeks. Initially, we have given aspirin a higher dose, and once the child has become febrile, you will reduce the dose and you have to continue it for 6 weeks. And what about further follow-up? You can discharge the child when he is febrile, but follow-up is very important. What we have to do is, do an echocardiogram at 10 to 14 days and also at 6 weeks from symptom onset, definitely in liaison with the cardiology department. The child should be followed up in the OPD 1 week after each echo. Strenuous activity should be avoided for 6 weeks. And very importantly, any live vaccines should be avoided for 3 months after IVIG. At 6 weeks echo, if everything is normal, no coronary aneurysms, we are doing echo to watch for coronary aneurysms. But if there is no aneurysm, you can stop aspirin. And if any single aneurysm is there, and it is less than 8 mm in diameter, continue aspirin 2 to 5 mg per kg once daily until aneurysm disappears. And have to follow up regularly with cardiology, and 6 monthly ECG and echo should be done. Lifelong follow-up should be there and have to avoid cardiovascular risk factors. And if there are multiple aneurysms, and if there is a giant aneurysm, that is the size more than 8 mm, or if there is stenosis, lifelong aspirin and warfarin should be given. So, if there is aneurysm, the child has to follow up with cardiology. If there is multiple aneurysm, have to continue aspirin and warfarin lifelong. Now, we have told there are some high-risk features in Kawasaki. In those cases, the treatment will include methylprednisolone also. What are the high-risk features? If IVIG has failed, a child less than 1 year, there is severe inflammation like liver dysfunction, persistently elevated CRP, hypoalbuminemia. Then the child presented in shock. There is evolving aneurysms in coronary or peripheral vessels, or there are features of hemophagocytic lymphohistiocytosis. If these are there, it is a high risk feature. So what are the features of HLH? If there is cytopenia involving more than 2 cell lines, hepatosplenomegaly, hypertriglyceridemia, hyperferritinemia, hypofibrinogenemia, and decreased ESR. These are the high risk features of Kawasaki disease. And let me end with this. There is atypical Kawasaki and incomplete Kawasaki. What is atypical Kawasaki? We have told the definite diagnostic criteria. But in atypical Kawasaki, there can be other features like renal involvement, pulmonary nodules, pleural involvement, diarrhea, vomiting, abdominal pain, and testicular swelling. What is incomplete Kawasaki? Fever will be there. 5 or more days fever will be there. But criteria, all the 4 criteria will not be there. Maybe 2 or 3 criteria will be there. So if the child falls in the typical age group of less than 5 years, you have to think Kawasaki and start treatment early, because early treatment reduces the mortality from coronary aneurysms. So goodbye everyone.